Welcome to Evidence-Based Cardiology Talks, the place for cardiologists to catch up on the latest, most significant research in contemporary cardiology.
It's good to be here. We're always trying to connect the evidence to our everyday practice.
And before we jump into today's deep dive, just a quick reminder, please subscribe to Evidence-Based Cardiology Talks on Spotify and also on YouTube. That way you won't miss out.
Definitely. Staying current is, well, it's essential in cardiology, and that's our goal here.
So today we're tackling a really major publication, the 2024 ESC Guidelines for Chronic Coronary Syndromes. And this discussion, like all our deep dives, is under the supervision of Dr. Caroli. You can find more at ddarcaroli.com.
These guidelines are quite substantial. They really represent, I think, an evolution in how we approach CCS.
Absolutely. It does feel like a move away from maybe simpler or more static models towards something much more dynamic and, frankly, complex.
That's a good way to put it. They offer a very comprehensive view. In Section 2.4, the What is New bit is probably the best place to see the main changes at a glance.
Okay, let's dive in now. Section 2.1 talks about these evolving pathophysiological concepts. What's the main shift there?
Well, the core idea is moving beyond just thinking about fixed blockages, epicardial stenosis as a sole cause. The new model brings in a wider range of things.
Like what, specifically?
Things like stabilized intramural hematomas, myocardial bridges, even coronary aneurysms are mentioned. But critically, it also emphasizes the functional side.
Functional side meaning?
Meaning issues with how the vessels work. So impaired vasodilation, increased vasoconstriction, or even overt spasm, and also structural changes in the microvasculature. It's a much broader pathophysiological landscape.
So it really forces us to think beyond just, is there a blockage or not?
Exactly. It means our diagnostic approach and our treatments need to account for this wider range of possibilities.
Which leads nicely into Section 2.2, the clinical presentations. The guidelines outline quite a few scenarios.
Yes, it's a real spectrum. You have the sort of classic symptomatic patients with stress-induced angina and obstructive CAD, but then importantly, you have patients with angina or ischemia due to those vasomotor or microvascular issues, ANOCA, INOCA.
Right, the ones without obstructive disease.
Precisely. And then there are patients post-ACS or post-revascularization, those with heart failure that might be ischemic, and even asymptomatic individuals where CAD has been detected incidentally.
It really underscores that CCS isn't a single entity, and patients can move between these states.
Yes, that's a key point. It's dynamic. Patients can shift between presentations, and critically, they can unfortunately progress to an acute coronary syndrome.
And the symptoms themselves aren't always specific to the underlying cause, whether it's obstructive, microvascular, or vasospastic.
That's right. We can't just rely on the description of pain. Age and sex also matter significantly here.
We know women often present differently, maybe more non-anginal symptoms, and have more microvascular disease. And the guidelines are moving away from that typical atypical non-anginal chest pain classification.
They are. Figure 3 shows this shift towards just describing the symptoms in detail. The precise study basically showed that the old classification didn't add much prognostically.
Oh, okay. And the Canadian Cardiovascular Society, or CCS, classification for angina severity, still used, but with caveats.
Yes, it's mentioned in Table 5 for grading effort angina, but the guidelines note its limitations. The symptom severity doesn't always neatly track with how bad the blockages are, and again, there can be differences between men and women.
Understood. Now, Section 2.3 talks about changing epidemiology and management. It seems like prevention is having an impact.
It does seem that way. There's a noted decline in the age-standardized prevalence of obstructive epicardial disease, likely due to, well, better primary prevention and effective medical therapies.
Which in turn means we need better diagnostic and risk prediction models, right?
Exactly. And that's where we see things like coronary CT angiography, CCTA, becoming more prominent as an initial test. The guidelines state it performs similarly to non-invasive stress testing for detecting ischemia.
Let's talk practical steps then. Section 3 outlines a 4-step approach to initial management. Can you walk us through that?
Sure. Step 1 is the basic clinical evaluation symptoms. ECG, blood tests, maybe chest x-ray or lung function tests if indicated, and crucially, rule out ACS first.
Okay. Step 1, initial assessment. Step 2.
Step 2 involves further cardiac exams, typically an echocardiogram, and estimating the clinical likelihood of obstructive CAD.
Step 3 then moves to more definitive diagnostic testing.
Yes, to actually confirm the CCS diagnosis and assess the patient's risk level.
And finally, Step 4 brings it all together.
Right. Lifestyle and risk factor management, starting disease-modifying meds, and then considering antianginals or even revascularization based on everything found.
A big part of step 2 is estimating that pretest likelihood of obstructive CAD covered in 3.2.1. The guidelines favor the RFCL model.
Yes, the risk factor-weighted clinical likelihood model. Figure 4 shows how it integrates symptoms, age, sex, and cardiovascular risk factors. Its advantage is it's relatively simple but maintains accuracy.
And it tends to put more people in the very low likelihood category.
Compared to the older ESC model, yes. And for those very low likelihood patients, the annual event rate is reassuringly low.
Does that change how we manage them?
It might mean less need for immediate further testing, though the guidelines do mention the coronary artery calcium score, the CSCSCL model, as potentially useful for refining risk even further in that very low likelihood group. It seems to be better at predicting MI and death.
Good point. And finding atherosclerosis elsewhere in the body also bumps up the suspicion for CAD. Recommendation Table 3 summarizes how to estimate and adjust this likelihood.
So once we have an idea of the likelihood, Section 3.3 deals with confirming the diagnosis. Let's start with non-invasive imaging, specifically CCTA in 3.3.1.
Right. The big advantage of CCTA is seeing the arteries directly, isn't it? Rather than just looking for downstream effects like ischemia.
Exactly. It gives us anatomical detail, and its diagnostic performance compared to invasive angiography is pretty good for detecting significant stenosis.
They also mention CT perfusion imaging.
Yes, CCTP. It adds functional information about blood flow, kind of like a DEXA scan, and it's validated against SPECT.
And CCTA can also tell us about plaque characteristics, which has prognostic value.
It can. Identifying high-risk plaque features might help stratify risk better, although we still need more standardization in how we report these findings.
Of course, CCTA isn't suitable for everyone. There are prerequisites.
True. Section 3.3.1.3 lists them: stable heart rate, ability to hold breath, checking kidney function, contrast allergies, and it can be limited by heavy calcification.
What about FFRCT, adding functional assessment to the CT scan?
FFRCT can estimate the functional significance of a stenosis seen on CCTA without extra stress or contrast. But its accuracy really depends on the quality of the initial CT images.
Okay, moving to non-invasive functional imaging. Stress echo comes up in recommendation table 9.
Stress echo is recommended especially for moderate to high likelihood patients to diagnose ischemia and estimate risk. A key limitation, though, is sometimes image quality, visualization issues.
And stress aspects or PE scans, section 3.3.2.
Both are accurate for detecting flow-limiting lesions and give prognostic info. The newer CZT cameras for SPECT mean less radiation and better accuracy. BET is very good, but often needs on-site tracer production.
Then there's stress CMR, cardiac MRI.
Stress CMR, covered in 3.3.2.4 and Table 4, is useful for assessing both ischemia and viability, particularly valuable in patients maybe with heart failure or complex anatomy.
What about the humble exercise ECG? Its role seems diminished.
It is. Recommendation Table 5 suggests it might have a limited role in refining risk in some low-likelihood patients, but it's generally not recommended if there are baseline ECG issues or the patient's on digoxin.
And ambulatory ECG monitoring.
Table 7 points out its use for evaluating symptoms like chest pain or palpitations, detecting silent ischemia, or looking for suspected vasospastic angina. Still has its place.
Finally, under diagnosis, we have the invasive tests in section 3.3.3, starting with ICA, invasive coronary angiography.
Still the gold standard for anatomy. The guidelines strongly recommend radial access through the wrist whenever feasible, due to lower complication rates. But it's not risk-free. There's still a small chance of major adverse events.
And crucially, if an intermediate stenosis is found during ICA, functional assessment is recommended.
Yes, very strongly. Class I recommendation in Table 12, using FFR, IFR, or maybe QFR to guide whether revascularization is actually needed for those intermediate lesions. It avoids unnecessary stenting.
Are there other invasive measures?
They mention things like CFR, HSR, CFC as complementary tools, and also resting indices or angiography-derived FFR, like VFFR, as alternatives. And importantly, the guidelines also mention assessing for microvascular dysfunction and spasm, especially if obstructive CAD is ruled out.
Okay, that covers the diagnostic pathway quite thoroughly. Let's shift to section 4, long-term management, lifestyle, meds, and revascularization.
Right, this is about managing the condition long-term and preventing events. Section 4.1 kicks off with risk discussion and lifestyle.
Emphasis on informed discussion and multidisciplinary approaches.
Absolutely, helping patients understand their risk and the benefits of therapy. Smoking cessation is huge, massive prognostic benefit. Weight management is also linked to better outcomes.
And exercise therapy, the FITT model.
Yes. Section 4.1.3 details the FITT approach: frequency, intensity, time, Type recommends moderate intensity continuous training, usually combining aerobic and resistance. HIIT might be an option for some,
But adherence is key.
always. And continuing through cardiac rehab, the guidelines also note contraindications to exercise.
Moving to medications for symptoms, antianginals, section 4.2.
The general strategy often starts with beta blockers or calcium channel blockers.
Yeah.
Combination therapy is common, and Figure 9 is helpful here, showing possible combos and what to avoid.
What about second-line agents?
If first line isn't enough or not tolerated, agents like nicorandil, ranelazine, ivabradine, trimetazidine come into play. Long-acting nitrates and ranelazine can also be add-on therapy. Ivabradine has specific indications in patients with lower LVEF.
Now, medical therapy specifically for event prevention, section 4.3, starting with antithrombotics in 4.3.1.
Okay, so antiplatelets like aspirin or clopidogrel are standard for secondary prevention after MI, PCI, or CBG. A big focus is DAPT duration balancing ischemic versus bleeding risk, especially in high bleeding risk patients, using definitions like RCHBR. Trials like Twilight are relevant here.
What about patients needing anticoagulation, like with AFib?
Managing AFib plus PCI is tricky. The trend, based on trials like Pioneer AF-PCI and Augustus, is towards OAC monotherapy after a relatively short period of combined therapy, usually favoring an LOA over warfarin. Triple therapy is generally minimized.
Okay, lipid lowering 4.3.2, still targeting LDL aggressively.
Definitely. The 2019 SCS targets still apply. Statins are first line, of course. Then ezetimibe, PCSK9 inhibitors, bempedoic acid, even inclisiran can be added sequentially if targets aren't met. And high-dose statins pre-elective PCI are recommended.
What about RAS blockers and RNIs in 4.3.3?
ACE inhibitors, or ARBs, are recommended for CCS patients with hypertension, LVEF, A40% diabetes, or CKD. The benefit seems less clear-cut in those with preserved LVEF without those other conditions. ARNIs would primarily be for concomitant heart failure.
And beta blockers for event prevention, 4.3.4?
Yes, particularly important post-MI and in patients with LV dysfunction for both symptoms and prognosis.
Then we have the newer players, SGLT2 inhibitors and GLP-1 receptor agonists. Recommendation table 20.
This is a big update. SGLT2 inhibitors with proven CV benefit are now recommended Class I for CCS patients with type 2 diabetes, regardless of their glucose control. GLP-1 RAs with proven benefit are considered Class IA.
And briefly, anti-inflammatory agents, section 4.3.5.
Trials like CANTOS, canakinumab, and the colchicine trials, Colcott, Lodoco-2, showed some promise, but methotrexate didn't pan out in CERT. So colchicine might be considered Class I in selected patients, but it's not routine yet due to side effects and needing more data.
Right. Let's tackle revascularization strategy, section 4.4. What are the guiding principles?
The main goal is improving symptoms and, in selected patients, prognosis, typically when medical therapy isn't enough. The ischemia trial is central here. It showed that in stable patients without left main disease or severely reduced LVEF, an early invasive strategy didn't reduce events compared to optimal medical therapy initially.
But the long-term follow-up, ischemia extend,
Suggested a potential late benefit for the invasive strategy, particularly regarding MI, maybe more so in those with multivessel disease. It's still debated.
What about patients with reduced LVEF ischemic cardiomyopathy, section 4.4?
That's complex. Historically, CBG was often preferred, but the recent revived BCIS2 trial was quite impactful. It showed that adding PCI to optimal medical therapy in patients with severe LV dysfunction and viable myocardium didn't actually reduce death or heart failure hospitalizations compared to medical therapy alone.
That really challenges some previous assumptions about viability testing guiding revascularization in this group.
It does. It emphasizes the importance of really optimizing medical therapy first.
Complete versus incomplete revascularization, 4.4.3.
The aim is generally complete revascularization if feasible and safe, but it's not always possible, especially with complex PCI. There's ongoing discussion about anatomical versus functional completeness. Santac's trial insights are relevant here.
And left main disease, section 4.4.4, PCI versus CBG.
Still a major discussion point. Trials like Excel and Noble compared PCI and CBG, generally similar midterm mortality but maybe higher stroke early with KBG and higher spontaneous MI later with PCI. The Syntax score helps to stratify risk and guide the choice. It really depends on the patient, the anatomy, complexity like bifurcations, and local expertise.
So the choice of modality, recommendation table 23, really comes down to
shared decision-making. It's crucial. Considering everything, patient factors, coronary anatomy, procedure risks, LVEF, patient preferences, and the expected outcomes from PCI versus CBG.
Section 5 touches on specific patient groups. Any key highlights there?
It covers older adults, Sex differences reinforcing women need the same preventive therapies, but HRT is not recommended. High bleeding risk patients, mentioning the ARC-HBR definition again and shorter DAPT, also covers patients with inflammatory diseases, hypertension, AFib, valve disease, CKD.
Cancer patients too.
Yes, discusses the cardio-oncology aspect, increased risk with some treatments, the need for multidisciplinary input for revascularization decisions, considering prognosis and drug interactions. HIV patients also have increased risk and drug interaction issues with ART and statins. And it mentions diverse groups, like South Asians potentially having more diffuse disease.
Okay. And screening asymptomatic individuals, Section 5.4, still generally risk score-based.
Yes, using scores like SCORE2 or SCORE2-OP for adults over 40 without known CVD. Opportunistic risk factor screening is okay, but its impact isn't proven.
What about coronary artery calcium swelling?
CAT can help refine risk estimates, especially for those near treatment thresholds for statins, maybe. But there aren't randomized trials supporting aspirin based on CAC alone. Opportunistic CAC on chest CT should be reported visually, but finding calcium alone in asymptomatic people doesn't automatically trigger further invasive testing based on current evidence.
Finally, this covers follow-up for patients with established CCS. What's the focus?
Regular follow-up is key. Assessing symptoms, risk factors, adherence to meds, monitoring for complications like heart failure or arrhythmias, optimizing therapy.
And if symptoms change or worsen?
Then non-invasive testing, CCTA or stress imaging, can provide prognostic information and guide whether therapy needs escalation, potentially including repeat revascularization. The section also briefly touches on managing PCI failure, like restenosis or stent thrombosis, and CABT graft failure.
Well, that was a comprehensive run-through of the key aspects of the 2024 ESC Guidelines for Chronic Coronary Syndromes. It's certainly a detailed and evolved approach.
It really is. It reflects how much our understanding has grown, incorporating functional aspects, advanced imaging, and nuanced approaches to medical therapy and revascularization. The emphasis on individualization and shared decision-making is stronger than ever.
Absolutely. So to wrap up, here's something for our listeners to think about. Given the growing focus on ANOCA and INOCA angina or ischemia without obstructive disease, how do you think future guidelines might evolve to better diagnose and treat these often challenging patients? What specific pathways or therapies might emerge?
That's a fantastic question. Refining diagnostics for microvascular dysfunction and vasospasm and finding targeted therapies beyond standard antianginals is definitely a major area for future development.
Lots to consider. Don't forget to subscribe to Evidence-Based Cardiology Talks on Spotify and YouTube to stay updated. Thanks for joining us for this deep dive.